I want to keep us moving so we have time for questions. It is also my pleasure to introduce our next speaker, Dr. Saraswati Vedam, who is a colleague, co-author, and collaborator. And she is the lead investigator of the Birthplace Lab and a professor of midwifery in the Faculty of Medicine at the University of British Columbia. Saraswati, you on?
I am. Can you hear me all right?
Yes, ma'am. Go ahead.
Okay. Thank you so much. And thank you, Dr. Scott, for that brilliant presentation and for your work in measurement. As you know, I have a similar passion. I come to you today from the traditional and unceded homelands of the Musqueam, Tsleil-Waututh, and Squamish nations in Western Canada. I have no conflicts to declare, although I am certainly grateful for the funding that I've had, my lab has had from various foundations primarily and institutes. And I'm especially grateful for the fellowship and wisdom of my co-authors and co-investigators on the studies that lead to today's presentation. Over the past decade, global health organizations have focused on describing the types and prevalence of mistreatment during pregnancy and childbirth in low and middle income countries, noting that the positive experience of care is an important component of quality and safety and an outcome in its own right. But as you've heard today and will continue to hear, measurement of disrespect and abuse in high resource countries, especially among historically oppressed communities, have not gained the same attention. One problem is that until recently, we've not had the measures and metrics of person-centered care that have been validated by service users. Dr. Scott just showed you one very intentional project to develop some, and I'm going to talk to you about some others. My lab is engaged in a number of community-based participatory action research projects that have led to the development of such measures. Today, I'm going to tell you about what happens when people with lived experience are the ones to ask and answer different questions. They are indeed the methods experts. In all of our studies at the Birthplace Lab, we start by creating a multi-stakeholder team. It's led by a steering council of service users. Together, we seek funding. We co-create the study tools. The service users tell us how to recruit, who to ask, how to recruit them, how to explore the findings. They help us identify the key messages, create the tools for sharing, and decide who needs to hear the story and how to tell the stories. Today, I will focus today on the results of one of the studies that we coordinated in collaboration with several community health organizations, clinicians, and service users. Because of the model for co-creation of the study tools and recruitment methods, we had participation from all 50 states, and as intended, robust engagement from communities of color. The Steering Council wanted to understand what care options are most important to pregnant families in the US. How do communities of color experience care? How do families decide where to give birth? And does place of birth or model of care affect their experiences? And in particular, what is this process of decision-making that they encounter during pregnancy and birth, including being heard and treated with respect? The survey was available in English and Spanish, and we started by building it through a literature review, looking at the domains that I showed you on the previous screen, where they identified these topics that they wanted to look at, and we went to look at what was already validated to measure those. And in fact, we only found a few measures that the service users felt were really relevant to their experience. So we adapted some and we designed some new questions. And then community members went through a formal process of rating each item for relevance, clarity, and importance. The final survey has quantitative and qualitative items and scales that describe what respectful care and mistreatment looks like from the service user's perspective, measuring experiences of stigma, racism, and abuse, as well as supportive, kind, and exceptional care. Our intent was to elicit data from underrepresented communities. We gathered data on slightly more than the US population proportion for Black and Indigenous respondents. And just to note that these are high-level categories, but participants were able to self-identify with a lot of detail on their race and ethnicity in their own words and own terms. And in the survey items, the items used for Native American Alaskan Natives were those Native American and Alaskan Native, and we are representing those people as respondents as Indigenous in these slides. Half of the sample gave birth in hospitals, which is of course, and half in homes and birth centers, which is of course not representative of birth location in the US. But we do note that there was a proportionally higher Black and Indigenous people proportionally higher in our data set delivered in hospitals. So I thought it was really important to examine the effect of birth location as well. And the large numbers in both cohorts allowed us to examine the differences by model of care. In the past few years, we've been working with a number of Black, Latinx, and Indigenous and South Asian scholars and people with lived experiences to examine this rich data set. Let's look at their findings. We asked, during your pregnancy, did you feel you needed the following? And it was a number of social services and help around mental health or social determinants of health, that the conditions that lead to social determinants of health. And the service user said, you can't just ask us, did we need it? What about, did someone help us get it? And as you can see from this slide, the red bars are pretty much absent for many of the services that they identified they needed from. Doctors Tanya Kamet and Keisha Good examined with this data set the unmet needs related to mental health counseling and depression treatment during pregnancy, as well as postpartum screening for depression, anxiety, and stress. Overall, 21% of participants reported seeking prenatal or pregnancy mental health services, and Black and Indigenous women were 2 to 3 times more likely to have unmet needs for support. We repeated this analysis for people who are seeking postpartum mental health, and we found the same thing. Mistreatment was significantly associated with postpartum mental health visits, even when they did access care. People reported on how important it was for them to lead decisions, and you can see from this slide that 91% of respondents said it was very important. This is a Likert scale, so this is the most important thing was that they lead decisions, and only 1% said that it was not important to lead decision. About a third wanted their provider's input. However, when they reported on who actually made the decisions for various procedures and interventions, this is for cesarean, most decisions for cesarean were made by the provider, represented by the green and blue pie sections there. So the Steering Council directed us to examine decision-making in more depth, and so we analyzed the connections between this scale, the Mother's Autonomy and Decision-Making Scale, which uses a Likert scale of answers to each of 7 items. They're represented here on the slide. And when you sum up their responses to these items, where they agree or disagree, you get an autonomy score. Higher scores mean more autonomy. When we then used the scores as an outcome measure, we found that respondents reported significantly lower autonomy when they gave birth in facilities and hospitals. Lower autonomy when they were cared for by hospital-based physicians and midwives versus community-based midwives. And I remind you that these are simple questions about whether or not they understood the option, whether they were told the options for treating any particular condition, whether they understood the options, whether they had time to understand those options, whether they were able to choose the options that they desired. We also looked at the Mothers on Respect Index scores as an outcome measure. The MOR index measures 3 constructs on how comfortable people felt asking questions, accepting or declining options, whether they felt discriminated against because of their identity or difference of opinion, and how that affected their behavior. Did it make them hold back their questions because they felt they would be seen as difficult, or they had a difference of opinion? Again, higher scores indicate experiences of more respect. We found that there were significant differences by race, and that people of color, in particular Indigenous, Black, and Hispanic people, reported the lowest levels of respect. This is the lowest 10th percentile of scores in this study. Dr. Palomi Niles, Melissa Gardia, and Nan Strauss of Every Mother Counts examined the intersection of model of care and place of birth, and found that midwifery clients who gave birth at home or in a freestanding birth center were 5 times as likely to report very high autonomy compared to patients who gave birth at the hospital or in a alongside birth center. Directed by our steering council, our first analysis and published article from the study focused on the most egregious forms of mistreatment, being shouted at, having treatment being withheld, being ignored, or physical abuse. Community members told us these are the types of mistreatment they have experienced. They wanted to see what others said. How often is this happening? Who is at most at risk for mistreatment? Sadly, we found that 1 in 6 women in our total sample experienced one or more types of these mistreatment. Being shouted at or scolded by a healthcare provider was the most commonly reported mistreatment in the US, followed by healthcare providers ignoring women, refusing the request for help, or failing to respond to requests for help in a reasonable amount of time. A large proportion described being threatened with the possibility of death for their babies. And rates were 2 in 6 among Black, Indigenous, and people of color, and higher with social disadvantage. In the same year, the WHO published an analysis from 4 low-income countries and found the same rate, 1 in 3 in LMICs and 1 in 3 in Black, Indigenous, and people of color communities of mistreatment in the United States. The way they gave birth affected their rates of mistreatment. And then, in fact, if they had an unplanned intervention, their experience of mistreatment went up, not down, when they were in a fragile situation. Community birth center settings were protective of mistreatment as well. And of course, it's not a surprise to say that their other identities, whether they had low socioeconomic status, pregnancy risk, or social risk, increased their risk for mistreatment. But when we stratified this analysis by race, additive factors that are known to interact with poor outcomes, when stratified by race, show that everybody is suffering, but the people who of color are suffering even more. There is definitely more mistreatment by race, linked simply to race. Especially as you see in the last line, the difference of opinion if you have a difference of opinion with your care provider about the right care for yourself or your baby, you're 83% more likely to experience mistreatment, 76% if you're white in our data set. Dr. Rachel Logan worked with us to examine data on consent and non-consent to procedures and pressure to accept interventions. And while about half of our total respondents said that they declined some aspect of care, women of color were 2 times more likely to have care providers perform the procedure against their will, or keep asking them until they agreed, or ask a midwife, doctor, or family member to convince them. The full regression model showed that BIPOC identity accounted for 39% of the variability in non-consent for procedures, and also significantly predicted pressure to accept procedures. Measuring quality of maternity care through patient-reported outcomes is critical to understand health inequities among communities and regions that carry the disproportionate burden of adverse outcomes. Dr. Zoe Julian did a region-specific analysis. Among respondents from the southeast of the United States, the odds of any mistreatment, low autonomy, or low respect were higher among Black and people of color participants. Irrespective of participant race, midwifery care in community birth settings was protective against mistreatment, low autonomy, and low respect compared to midwife or physician hospital births. But access to midwifery, as we know, is very inconsistent and often not paid for state by state. Dr. Dana Solomon looked at relationships between BMI and mistreatment, autonomy, respectful care, non-consensual care, disparities in access, and social determinants of care, and found that larger people were almost 5 times as likely as those with a normal BMI to report mistreatment, including loss of autonomy, being shouted at, scolded, or threatened, being ignored, refused, or receiving no response to requests for help. Why do these findings matter? We know from careful quality assessment studies that being ignored and delays are directly related to maternal deaths. Leave aside that these are outcomes in their own right and human rights issues. It is it's difficult to ignore that mistreatment and the way people are treated, experience of care, is a quality care issue. So what about the other side of the card? Our service users said it was very important for us to measure not just what causes harm, but also what helps them survive, succeed, and thrive. And you can see from this slide that it's not the healthcare system or healthcare providers or government agencies, it's their communities, their immediate family, friends, and communities. And yet, finding a doctor or midwife who shared their heritage, race, ethnic, or cultural background was quite difficult, particularly if they were Black, Indigenous, or Latina. Jennifer Almanza and Dr. Rachel Hardiman and colleagues compared experiences among birthing people receiving care in community birth settings in the Giving Voice study with care provided by Roots Community Birth Center, which is a Black-led, culturally centered community birth center in Minneapolis, Minnesota. Regardless of race, Roots clients reported statistically significant higher total MADM and MORI scores. And they, when compared to Black, Indigenous, and people of color clients in the national sample, when we compared that to the Roots sample, MADM and MORI scores were statistically higher for clients receiving culturally centered care at Roots. So it was better for Black and Indigenous people, and it was better for all people. Since 2017, these tools have been applied globally in over 40 countries, but they're just now getting some uptake in the US. And as you heard from Dr. Scott, her groundbreaking work around obstetric racism and measurement, that is a very new thing and needs more uptake. We have many more, much more data. It was a large study, and we have a lot more wonderful early career scholars who are engaging with the data, and you will see these topics being addressed, from VBAC to nativity and mistreatment. And my question for you today is, what if we changed the way we looked at birth research? What if we measured undisturbed birth rates alongside cesarean rates, upright spontaneous births alongside vacuum and forceps assisted? What if we looked at the effects of model of care, respect and disrespect alongside service delivery, and the impact of place of birth, and of course the impact of racism and anti-racism in healthcare? We're currently using these person-centered measures in a national study in Canada with a focus on those seldom heard, people with various identities, circumstances, and backgrounds. And we've done more work to have a registry of person-centered measurement items. And you can find more information about that at our lab. Thank you.